Heal the blanket way, amniotic membrane inlay overlay grafting for persistent epithelial defects. No financial disclosure or conflict of interest. Coming to the introduction, persistent epithelial defects can cause prolonged inflammation of the ocular surface, damaging the corneal stem cells, epithelial basement membrane, resulting in corneal scarring, neovascularization, decreased vision. MMP produced by keratocytes, epithelial cells, neutrophils can cause progressive stromal ulceration with risk of perforation. Amnion prevents inflammatory cell infiltration and reduces apoptosis in keratocytes after transplantation on the corneal surface. The aim of the study is to determine the effect of AMT on persistent corneal epithelial defects and to compare the efficacy between inlay and overlay techniques. So a retrospective study of 20 eyes who underwent AMT for PED was done. The use of AMT was restricted to those patients in whom all previous measures, including BCL and tarsography, failed. Amniotic membrane was placed on the surface of the cornea in 12 overlay group A and 8 inlay group B fashion. So coming to the results, PED healed after first AMT in 16 eyes with an average of 21 days after surgery and recurred in 4 eyes, as we can see in this pie diagram. So coming to the results, which are elaborated. So among the 12 eyes that were treated with AMT group A, overlay fashion, PED healed after the first AMT in 9 eyes with an average of 20.5 days and recurred in 3 eyes. 2 eyes healed with repeat AMT by overlay technique. So one eye that showed recurrence did not heal with repeat AMT overlay technique and needed repeat lamellar keratoplasty. So these are the few pictures of those patients that were treated successfully by AMG overlay technique, in which an AMG of 12 to 14 mm in diameter was secured on the surface of the cornea in the mid-peripheral cornea with NO interrupted nylon sutures, and this was secured in place by placing a BCL. So we noticed the dissolution of the amnion in 4 weeks with completely good results in most of the patients. So in inlay technique, among the 8 eyes that were treated with inlay, the PD healed after the first AMT in 7 eyes and recurred in 1 eye, with an average healing period of 18.5 days after the AMT inlay technique, which did not statistically differ from those of the group A cases. So in the inlay technique, the size of the epithelial defect was first measured. It was cleaned of all the debris, and an amnion, which was about 1 mm more than size of the epithelial defect, was secured in place with 10 nylon interrupted sutures, and then an AMG was placed in an overlay fashion on top of it and was secured in place with a BCL. So our results show that there was no statistically significant difference in recurrence rate between AMT overlay and inlay technique. There was a slight difference in success rate after the first AMT when the inlay technique was used. A stable ocular surface during the follow-up was noted in all patients post-AMG overlay. AMT can improve visual acuity by both corneal surface restoration and improvement of corneal transparency. In our study, the average visual acuity improved after AMT in both overlay and inlay groups, but the difference between the preoperative and final visual acuities was not statistically significant. To conclude, AMT inlay group had better postoperative outcomes in terms of reduced recurrence of PED, although the healing time was not statistically different in both the groups. The use of AMT for PED should be reserved for those cases in which removal of medications toxic to the epithelium, aggressive lubrication, and ocular surface protection with BCL and tarsography failed to control the inflammation and closure of the defect. We did not find any difference between the overlay and inlay techniques in terms of healing, recurrence rate, and effect on visual rehabilitation. Further studies are required to confirm our results and to compare AMT with other strategies in treatments of PED and stromal ulcers, and to compare results after different techniques of transplantation. These are my references, and thank you.
Hi, Soumya. Can you tell me what is the originality of your study? And you mentioned that there was a difference in the recurrence rate which was not statistically significant. So can you go back to the conclusion slide? Yeah, the one before this. Okay, so point 1. So what was your in discussion you mentioned that there was no statistically significant difference. Then you go back to the next slide.
Like we just wanted to tell that there was a slightly better healing when the AMD inlay technique was used, because we are tailored the inlay technique. We are tailor cutting the amnion for the epithelial defect, and then again it was closed by an overlay amnion, and then it was secured in place with a BCL. So the thing is, we are adding more of epithelial growth factors and transforming growth factors. So the epithelial apoptosis has decreased, and it has led to better outcomes.
I'm not asking about how it happened, but what is one message that you want to give, and what is the originality of your study?
The message that we want to give is like when there are some cases of refractive corneal ulcers or exposure keratopathy or neurotropic keratitis which are not healing, the BCL or tarsographies and all other measures have failed. So instead of going for a TPK, in cases of, especially in our cases, more of infective keratitis which are showing epithelial basement membrane erosion with stromal ulceration, which are in the risk of perforation, and we don't want to go to such a, we don't want it to go to the progress of perforation. So when you are seeing the stromal ulceration is deepening or anything, then it's better to go for closure.
Do you think in such an inflamed eye, amniotic membrane is going to hold on?
Madam, normally it does hold on with BCL in most of the cases, because we are also giving adjunct inflammation.
TABCL would be a better option than an amniotic membrane grafting.
Ma'am, because BCL also acts as a double-edged sword, because sometimes it can cause an hypoxic effect and can increase the inflammation and infiltrate also. So when you have an amnion along with BCL, it does help in resolution of the epithelial defect, because when the epithelial defect is healed, then you can see a difference in the infection healing rate also, and so that the patient does not end up in a TPK, he does end up in a macular scar with a smoothened surface, and you can plan for a PKP later, or you can go for any other refractive surgery.
Thank you.
Thank you so much.
Dr. Marian Polly. Dr. Shefali Mazumdar.
Good afternoon, judges and everyone out here. I'm going to share a case series of 12 patients of unilateral total LACD post-chemical injury who underwent autologous SLED with minimum post-operative follow-up of 1 year. And all these patients have been evaluated in terms of ocular surface stability, BCVA and CCT during this period. This table is showing pre-operative baseline characteristics of all the patients. I would like to highlight some key features, like mean duration between chemical injury and SLED in this period. In this study group was 2.5 years. Alkali burns outnumbered acid burns. Surgical intervention in the acute stage in the form of alloslate was found in 1, AMT in 2. Simlifera was present 10 out of 12 cases, and pre-operative UCVA ranged between hand movement to 1/60 in all cases. So after ocular examination and documentation, ASOCT was done to note down the thickness of pannus and thickness of residual cornea beneath the pannus, and the thinnest residual cornea which I dealt in this case series was of 250 microns. So here is a small video showing how we harvest limbal biopsy. The initial steps are same as we do in pterygium surgery, but here we keep on dissecting towards the limbus till no more further dissection can be carried out with vanas. Then with crescent knife, I take usually 4 mm of limbal biopsy in all my cases. Here I am taking larger conjunctival graft than limbal biopsy to deal with extensive simlifera of this patient. Now in recipient eye, after releasing simlifera superiorly and inferiorly, I did little more peritomy on both sides, and 1 to 2 mm from the limbus I started deeper dissection to reach beneath the pannus, and once I got the plane, I dissected the whole pannus from the cornea. Then up to 3 to 4 mm from the limbus, I dissected all the adhesions, and I tried to save conjunctiva as much as I could. Then I placed conjunctival autograft in the areas of previous simlifera, secured it with fibrin glue. Then I placed amniotic membrane, again used fibrin glue and stroma down, and extra amniotic membrane was trimmed, and then I tucked the amniotic membrane with the help of blunt instruments all around in the conjunctival pockets. I give running sutures with 10 nylon starting just behind the conjunctival autograft to give it more protection. Then I cut limbal biopsy into 8 to 10 pieces in all my cases, and place all these pieces in the mid-periphery, secured all the pieces with fibrin glue, placed PCL, and I do tarsography in all my cases. So the mean duration of complete ocular surface epithelialization in this study was 26 plus minus 3 days. Here we are showing two types of cases. In case 1, we have done only slit. In case 2, we have done slit with crag. And you can see with the passage of time, cornea became clearer and clearer. We encountered some complications as well. Like this patient developed large granuloma at the 3 months post-operative follow-up despite pinning autograph in the area of previous imlifera. He was not responding to topical steroids, so it started oral steroid and slowly it was completely resolved within 6 weeks without any surgical intervention. This patient was doing good till 4 months post-operative follow-up. Then he developed sterile corneal melt, not responding to medical treatment, so I did multi-layer amniotic membrane transplantation. Then leukomatous grade corneal scar with thinning in the center developed. For this, I did bit bubble DALK surgery for visual rehabilitation, and then he regained 6/12 part vision after this. Another case, it was a case of failed slit with MADCAT. I did triple procedure along with slit. In this case, he regained 636 vision. He was doing good till 2 years of follow-up, but again in the failed stage. So as far as the visual acuity is concerned, out of 12 cases, in 10 cases visual acuity improved significantly from hand movement to 1/60 preoperative vision to 636 to 6/9 after a year follow-up. One of our cases has been published in Cornea Open. So journey I just started 2 years ago and seemed very difficult, turned out really rewarding for patients as well as for me. Thank you.
Have you noted for infection from which the graft is taken? Any infection was there from the eye?
For
You have
that
taken
case,
the graft.
sterile corneal melt case, sir?
No. Does any of the cases have you got infection from which the graft tube broke?
No, sir. No infection we have reported.
And any treatment you have done for that? Post-operative antibiotic?
Post-operatively, we started topical steroids, sir, 1% prednisolone acetate with tapering doses, and antibiotic.
Other eye?
Other eye, yes, sir. Antibiotics. Sometimes I put BCL also for early healing.
I just wanted to make one comment that in few of the slides you have put the patient's name. So ethically it is not correct. Just can remove it. We have to. Thank you. Very nice case series. Thank you.
Dr. Jitendra,
Dr. Jitendra.
Dr. Ishan Tilak. एक्सेंट कर दीजिए एक मिनट.
Good afternoon, everybody. So the title of my study was Association between Dry Eye Disease and Corneal Endothelium and Age-Matched Analysis.
Con?
So dry eye disease is believed to be a disease of the ocular surface, but does this dry eye disease affect the corneal endothelium? That question comes in our mind again and again. Dry eye disease is associated with changes in tear film osmolarity. It has a change in inflammation and inflammatory biomarkers which cause a change in the ocular surface. There have been studies where endothelium is altered in dry eye disease, but there is none such study in the Indian population. Hence, the aim of our study was to assess corneal endothelial changes in patients with dry eye disease and compare it to a group of age-matched normals. The study population was 20 to 60 years. The population who were excluded was any previous history of intraocular surgery, any history of instilling ocular eye drops, any history of using contact lenses, because all these pathologies have been known to affect the corneal architecture. The subjects underwent OSDI questionnaire, TBUT, Schirmer's. They were separated into two groups based on the TWES2 classification. If OSDI more than 13 in any of the two, that is tear film breakup time of more than 10 or Schirmer's of less than 15, into dry eye disease group and into normals. Both the groups then underwent specular biomicroscopy, the non-contact specular biomicroscopy, to assess the endothelial parameters. Specular count was repeated thrice to rule out any error, and results were analyzed. In the dry eye group, there were 59 individuals, while in the normal, there were 55. The gender distribution was males and females were almost similar. The mean age of dry eye group and normals was almost same, with a p-value of 0.95. OSDI, Schirmer's and tear film breakup time were significantly poorer for dry eye group, confirming the diagnosis of dry eye disease. The interesting point on analysis of the endothelial parameters, there was significant reduction in endothelial cell density and the hexagonality in the dry eye group when compared to the age-matched normals. On the other hand, there was an increase in coefficient of variance in average cell area for the dry eye disease group. Central cornea thickness remained same for both the groups. So our study indicated there is a significant involvement of the corneal endothelium in dry eye disease, and it is not only the disease of the ocular surface which conventionally it is believed to. Now the mechanism why dry eye disease affects endothelium, this is still unproven, but there have been few reports in American journal saying there is reduced subbasal nerve density in dry eye disease, or the inflammation on the ocular surface which penetrates through the layers of the cornea, causing a reduction in endothelial parameters. The limitations of the study was the diagnosis of dry eye disease was based on Schirmer's, T-Buts, and all these tests are very subjective and depends on the person who is performing it. And there was unequal distribution of participants in mild and moderate, so we could not prove whether severity of dry eye also affects severity of the endothelial damage. To conclude, patients with dry eye disease had poor endothelial parameters when compared to age-matched normals. Thus, dry eye disease is one thing which needs to be highlighted before taking up a patient for any ocular surgery, say cataract surgery. Thank you.
So I have two questions. One is Schirmer, you took a Schirmer cutoff of less than 15.
Yes, ma'am.
So if you had taken less than 10, then it would have been a much better, I mean, the dry eye versus non-dry eye. So 10 to 15, usually we do not consider them as dry eye. That is one thing. And so what do you think could be the possible mechanism?
I have read few articles which say the endothelial cell the nerve density is affected in dry eye, and also the immune mediated changes occurring on the ocular surface penetrate through the layers of the cornea, having endothelial cell loss.
So if you were a researcher, clinical person with a grant, then what would be your next step?
My next statement would be to look into immune guided.
How would you do that?
Say look into which interleukins or which anti-inflammatory markers we can target to reduce those effects on the surface, protect the endothelium, because eventually at 60, 80, everybody needs to undergo cataract surgery, everybody needs to undergo some ocular surgery. And if we know patient has dry eye, with age also dry eye increases, which is a known fact.
So were all your patients pseudophakic or phakic? Have you taken a note of that?
Yes, ma'am. All pseudophakic, previous history of ocular surgeries, contact lens were excluded from the study.
So all were phakics?
All were phakics.
Okay, thank you.
You are Dr. Ishan.
Dr. Patade.
Good afternoon, everyone. Today I'll be talking on light, a novel way to treat chalazion. So chalazion, as we know, is an inflammatory lesion of the eyelid and caused by obstruction of meibomian and Zeiss gland. So the current management which we see in chalazion is usually asking the patients for a good lid hygiene, incision and curettage, or giving intralesional injection of steroids. So recent studies have shown that intense pulse light, when applied close to the lids, have reduced the symptoms of dry eyes due to the meibomian gland dysfunction. So it was therefore interesting to examine if the IPL could also be helpful in the management of chalazion. So our purpose was to see the efficacy of IPL for the treatment of chalazion. We had included the acute, the early, chronic and recurrent chalazion, and the only exclusion criteria was Fitzpatrick skin grade 6. And treatment was 1 or more IPL sittings at an interval of 1 month. So the device used was luminous M22 with a fluence of 10 to 12 joules per centimeter square. The pulse structure was triplets and the wavelength range was around 560 or 590 to 1200 nanometer, and the treatment area was cheeks, below the lower eyelids and the nose. So this is how, this is the filter and the cool light guided thing from which the IPL is given to the patients. So the pre-IPL, we had these patients who had acute, recurrent and chronic chalazions, and there were many patients with no previous treatment. There were patients who had undergone incision and curettage, and there were patients who had only taken the lid hygiene. So there were 58 eyes around, eyelids of 50 patients which we had considered for our study. 1 to 3 of IPL sessions were given. So in every session there were around 1 to 4 sittings, and 80% of the patients almost showed complete resolutions with 1 to 4 sittings, and 20% shows around partial resolution with multiple sittings, but only the 4 sittings were given maximum. And none of the patients showed with any other complications, and the early chalazion, the smaller ones needed only maximum 1 sitting for the complete resolution, and recurrent and the chronic ones required more sittings. So this is one of the patients which we had done the IPL treatment. On the left side what we can see is the patient with the pre-IPL, and on the right side is the patient with the post-IPL, showing the reduction in the chalazion. This is one more picture in which we have everted the lid of the patient and seen pre-IPL there were these multiple chalazions present, and post-IPL after 1 sitting there was reduction in the size of the chalazion. These are the other patients which we had done in the similar way, showing a promising result for the reduction in the size of chalazion. So to conclude with, I would like to tell that it is a safe and effective way of treating chalazion, especially if the patients are coming to us with recurrent chalazion and long-standing cases. And it is yet another one technique added to the armamentarium of treating chalazion, though the long-term results are yet to be studied. Thank you.
Do you consider your number of cases are small?
Yes, sir.
So
that
you
is
could
one
have
of,
taken a,
yes, sir. We need to take on more, because we initially were doing this for the dry eyes, patients who were presenting us with the meibomian gland dysfunction. But later
have you confirmed it through mammography, or have you confirmed it through mammography?
Yes, sir. They definitely had better this thing. The patients were also symptomatically very much better, and the need for lubricating eye drops was also reduced in those patients.
Apart from putting the scalpel onto the patient's eye, do you find any other advantage? Because if the underlying pathology is there, if the lid hygiene is poor, whether you do surgery or whether you take the patient for IPL, the problem will be recurrent, it will keep coming. So do you find actually on ground any advantage in this?
So yes, sir. So there were many patients who had, we had actually undertaken their incision and curettage like multiple times, and then they were like we don't want an intervention like that is
That part has
painful,
been,
yeah.
I've already said it. Apart from surgical intervention, do you find any other advantage?
The recurrence rate had reduced, sir, in the patients, and that was more, the patients were more comfortable also at the same time.
Quick question.
Yes.
How did you exclude the Fitzpatrick type 6?
So basically there were other studies, ma'am, in which they had excluded Fitzpatrick 5 and 6 both because of the more melanocytes in that skin type.
Category.
But we in our center had tried for Fitzpatrick grade 5 because the initial studies were only done till 4, and so we thought we would go one step extra and we would go for Fitzpatrick 5. Fitzpatrick 6 was not included, and also there were no patients with Fitzpatrick grade 6 as such available at the center too.
Okay, thank you.
Yeah, thank you, ma'am.
Thank you, sir.
So do we have Dr. Marian or Dr. Jitendra?
Marian.
Marian, please.
Late. She's late.
1352.
Your session. Competitive
Second.
session.
Achha.
Good evening, judges.
Mike.
My presentation is on utility of masquerade procedure in globe salvage. Masquerade procedure is an old procedure poorly described in literature, done in extensive eyelid loss, where residual conjunctiva is used to reconstruct posterior lamella and split thickness skin graft is used for anterior lamella. It is usually done in extensive burns and in air blephron, but the disadvantage is the lid is unstable and you can have lag of thalamus. So this is a case series. The surgical technique is first the lid is split into anterior and posterior, whatever lid remaining is split into anterior and posterior lamella. Then posterior lamella is sutured together with absorbable suture. This is the recipient one ready to accept the skin graft. This is, I use full thickness skin graft in this, and the full thickness skin graft is sutured to the bed with the absorbable sutures. In the postoperative period, bolster dressing kept for 1 week, and the central 2/3 of the flap is divided at 2 months and form the lid margin. Then assess the corneal status and further flap division at 3 months, retaining the flap at both the canthi in order to prevent the lid malpositions. So this is my first case, 46 years male, presented to us with hot water burns. He had already undergone multiple reconstructions elsewhere and referred for evisceration. On examination, there is a lag of thalamus with a perforated cornea. So he underwent masculine procedure and along with penetrating keratoplasty and lensectomy. So postoperatively, this is his postoperative picture, retaining the flap at canthi and the improvement in lag of thalamus, and he has retained his PL vision and improved hand movements. This is my second patient. She is a 7 years female, known case of popliteal terrier syndrome with bilateral eyelid coloboma and total lag of thalamus. With exposure keratopathy in both eyes. Right eye, there is a vascularized corneal opacity. Left eye, there is a perforated corneal ulcer, and this is a total lag of thalamus. She underwent masquerade procedure. This is a postoperative picture with the flap in situ, and after partial flap division, this is the picture, and at 8 months follow, the left eye has gone to phthisis, right eye the vascularization has improved, but there is a corneal opacity remaining, for which she is awaiting anterolamellar keratoplasty. So coming to discussion, masquerade procedure is a historical procedure where the globe salvage is possible where all other measures fail. I have done few modifications in the originally described procedure where full thickness skin graft has been used instead of split thickness skin graft, and sequential flap division with retention of the flap at canthi to prevent lid malpositions. Coming to the literature review, only very few reports are there. The biggest series was used by Leo et al. In 5 cases of burns where he has used full thickness skin graft. In the other series where only 2 patients and they have used full thickness skin graft, they have graft contracture. So masquerade procedure is a versatile option to rescue the globe and ocular surface in a very challenging situations. These are my references. Thank you.
Questions? Not my cup of tea. Any questions, sir?
No. Actually, you presented 2 cases, no?
Yeah.
And how frequently at your center you do that?
How frequently?
At your center you did that?
No, it's very
there
rare.
are more cases or?
No. Only I have done total 3. These
Total
are the
3?
Total
And out
3.
of that 2.
Yeah. This
Right.
is the 2 I have presented.
Thank you, madam. Can we have the timer, please?
And the slides?
Start.
Good afternoon, everyone. My study is effect of pulse dose oral azithromycin in management of meibomian gland dysfunction. According to the international workshop, meibomian gland dysfunction is defined as a chronic diffuse abnormality of the meibomian gland which is characterized by terminal duct obstruction or qualitative or quantitative changes in the glandular secretion. And this leads to tear film abnormalities due to evaporative dry eye, ocular surface irritation, and clinically apparent inflammation. Meibomian gland dysfunction is a common clinical condition but is an underdiagnosed and undertreated disease. And the prevalence increases with age due to alteration in the lipid with age. And the conventional management includes lid hygiene, warm compression, lid massage, and antibiotic steroids and other antibiotics like tetracyclines. In our study, we used azithromycin, which is a broad spectrum macrolide antibiotic with a long half-life and high degree of tissue penetration, and it has anti-inflammatory and lipid regulating effect. So the objective of our study is to determine the effect of pulse dose azithromycin in patients with refractory MGD. Ours was a hospital-based prospective interventional study conducted on 33 patients with refractory MGD. To them, we administered oral azithromycin 1 gram once a week for 3 weeks, and follow-up was done at 3 weeks. And to all of them, we had advised them to continue the topical medications which they were already on. And we assessed their subjective symptoms as well as plugging and vascularity of lid margin, tear film breakup time, corneal conjunctival fluorescent staining score, and Schirmer test value before and after treatment. We included patients with refractory MGD and excluded patients who were already on other oral antibiotics like tetracyclines. These are the slit lamp photograph of our patients showing plugging of meibomian gland and foamy discharge. In our study, majority of patients belong to the 6th decade with mean age of presentation of 61 years with male preponderance. And out of 33 patients, 21 patients showed symptomatic improvement at 3 weeks. Also, there was statistically significant improvement which was noted in tear film breakup time, which was P.02, Schirmer test value, as well as conjunctival corneal surface staining. So, in majority of patients, there was improvement in symptoms following administration of pulse dose of oral azithromycin. Also, no adverse events were reported by any of the subjects, and they were compliant with the pulse dose regimen. Similar study which was conducted by Green et al. In Department of Ophthalmology, California, showed similar results. Also, study conducted by Upapong et al. Showed that oral azithromycin had equal efficacy and fewer gastrointestinal adverse effects than oral doxycycline in MGD management. And study conducted by Kashkoli et al. Also showed that there was with oral azithromycin there was betterment of clinical response, better effect in improving signs, and shorter duration of treatment than oral doxycycline. So from our study we concluded that oral azithromycin pulse dose therapy for 3 weeks was found to be effective in management of MGD with short-term treatment and fewer side effects. Thank you. These are my references.
Some problem with the mic. Are you able to hear me?
Yes, ma'am.
Okay, so I have a couple of questions for you. Yes. First is you mentioned what was the staining grade that you used? What was the staining scoring system that you used in your study? You said there was a improvement in scores. What was
the? You mean the question?
Which staining? Which scores? No, what was the staining, what was the method that you followed? I understand with fluorescein you will do with a yellow light, yellow filter, but which grading did you follow? Whether was it a National Eye Institute grade? Oxford grade, that you have to mention, okay. Right? Yes, and symptomatic, what do you mean by symptomatic improvement?
Like patients, like we...
How did you grade it? How did
questionnaire, ma'am.
Speed questionnaire.
Speed questionnaire, ma'am.
Speed questionnaire. Okay, and there were 2 photos where you had shown A and B. So are they are these already published?
No, ma'am.
So A and B you have to put the legends. If you are doing A, B, then you have to put the legends, yes, what it means. Okay, those Frothy secretions. So you have to put those legends. Yes, thank you.
Thank you, ma'am.
Dr. Rohit Bang.
Dr. Bang? Do we have Dr. Bang with us?
No, next one.
Dr.
Kunal Mandlik.
Dr. Bang is not there. Dr. Mandli. Dr. Mandli.
Thank you, judges and AIOC for the opportunity. So my topic for today is use of topical tacrolimus as an adjunctive therapy in mycotic corneal ulcers. So as we know, infectious keratitis is most common cause of vision loss in developing countries, and in severe cases, we need to do therapeutic keratoplasty in those cases. Tacrolimus is a potent immunosuppressant of T cell proliferation. It uses inhibition of calcineurin signaling pathways. It has both anti-inflammatory and antifungal properties. So our aim of study was to determine the addition of topical tacrolimus in patients who underwent therapeutic keratoplasty for fungal ulcers, whether it was beneficial in terms of graft clarity. So in all, 13 patients were screened with smear and culture positive for fungal ulcers who required therapeutic keratoplasty, these patients were already on topical natamycin hourly, and post-therapeutic keratoplasty, we added tacrolimus ointment 0.1% thrice a day, along with cycloplegics and analgesics. The patients were followed up until 3 months. So the average age of our patients was around 62 years, and mean duration of the symptoms of presentation was around 9 days. Only one patient had pre-existing history of diabetes mellitus. So we did culture, we got culture on agar. These are our results, like 3 were fusarium, 5 were aspergillus, and 1 was pseudosporium. Rest were culture negative. So the average size of our ulcer in the patients was around 7 mm. So considering the size, average donor graft was around 9 mm, and in 8 cases we had removed the crystalline lens during therapeutic keratoplasty. So we had used optical quality graft. So our average cell density of donor corneal buttons was around 2400. And in those 2 patients required regraft due to graft reinfection. After 3 months of follow-up, we found that 2 had clear graft, 2 had mild edema, and 2 had moderate edema, whereas 3 had severe edema. Except for 2 patients, other patients had good anatomical integrity, which had a good potential for optical keratoplasties. So in clinical implications, we can say that topical tacrolimus is efficient in controlling post-operative inflammation after therapeutic keratoplasty. Unlike topical steroids, we normally are doubtful whether to start them or not because they can precipitate recurrent graft infections in fungal keratitis. So in literature, we have Zhang et al. From China. They also did a retrospective analysis of 20 patients where topical tacrolimus eye drops of 0.1% were administered 4 times per day. And they also concluded that topical tacrolimus facilitated in reduction in intraocular inflammation, which extends the long-term survival of the grafts. So few limitations of our study, as it was like a pilot study, the sample size was small, so it requires a prospective study with a large sample size, which we are undergoing at present with this group which we collaborated for MUT1 and MUT2 from Arvind. So a long-term follow-up is already, the study is going on now. So in conclusion, the use of topical tacrolimus might have beneficial effect on graft outcomes and improving the survival rate and reducing the graft reinfections. Thank you.
So what do you think are the other factors that can affect the outcome of keratoplasty in fungal keratitis?
Maximum, first is the graft quality, optical tissue, what we use.
Now host, first tell me about the patient's condition. The
patient's
host
condition,
yes.
Yeah, the inflammation, how much the graft size, the infiltrate size. If the infiltrate is more than 6 to 7 mm, the inflammation in the anterior chamber inflammation also counts for that. If anterior chamber inflammation is more, then we can expect a bad outcome in the post-operative phase. Because of the higher inflammation, there are immune melts also seen in post-therapeutic keratoplasty. But we don't, in cases of fungal keratitis, post-therapeutic keratoplasty, we are very doubtful to start steroids to
No,
reduce
that
their
is fine.
inflammation.
That is fine. But what are the host factors that can affect the outcome? My question is, what do you think are the factors in the host? One you said was the size of the ulcer.
Yeah.
And
The
few
host
other
immune
things.
mechanism, that's why
No,
we
that
are
we cannot
suppressing
see.
that.
That
Yeah.
we cannot see in slit lamp. So what are the other factors that we can see and know that
The AC
this
reaction, the hypopion in the anterior chamber, that that concludes that the intraocular inflammation is high. If we find exudates beyond the iris plane, if it is keratitis along with endophthalmitis, that means that the inflammation is high in the eye. So those patients have bad outcomes. So in those cases, additional use of topical tacrolimus can be beneficial. These are just pilot study data.
So what is your outcome? How would you, what would be the outcome, how would you grade your outcome?
So we graded our outcome on the basis of post-op graph clarity. Because we had used an optical clarity graph, so there was no bias that the pre-op cell counts were less, and because of that the clarity was less post-operatively. So our average quality cell density on the graphs which we used was around 2400. So it was an optical quality graph.
Post-operative outcome.
Post-operative outcome was good. Post-operative two were clear graphs, where two had mild edema. We graded the clarity of the graft on mild, moderate, severe edema and clear grafts. So like that we graded to see that inflammation was reduced. Because of the high inflammation, normally it leads to graft failures. So graft failures is
so it was only the graft clarity that you used as a reference scale to see the outcome.
Yes.
Thank you.
Yeah. Thanks a lot.
And how many cases you have told?
13. Ideally,
13.
Actually we had taken 15, but two patients dropped out. That's why we removed the two patients from that. Now we are with the Proctor Foundation from US. We are undergoing the long-term trial with that. Those where we did the MUT1 and MUT2 with them in Arvin. Thank you. Yeah.
No questions from the audience. Sorry. Not in a competitive session.
Okay. Thanks a lot, Nav.
Can't entertain audience questions. You ask him afterwards.
Dr. Bang is not there,
No. Is Dr. Bang here?
Dr. Bang, Dr. Sangeeta.
Good afternoon, judges. Good afternoon, everyone. My presentation is on correlation of histopathological features and clinical findings in pterygium. As we all know, pterygium is a fibrovascular subepithelial growth of allostotic degenerative bulbar conjunctiva over the limbus onto the cornea. It is a common ocular disorder with a prevalence of 0.3% to 29%. Hot climate and UV radiation are identified to be the most important risk factors. So, and here surgical excision is the most important treatment option, which is preferred for cosmetic reasons as well as astigmatism. And complications of this the common complication is recurrence. So another ocular surface disorder which share a similar risk factor, that is UV light, has a potential to coexist with pterygium is ocular surface squamous neoplasia. The prevalence of OSS in pterygia varies from 5 to 30%, and this depends on the UV exposure and patient's immune status having similar symptoms with serious implications, making the diagnosis more challenging. So the aim of our study was to correlate the clinical findings with the histopathological features of pterygium. So this was a retrospective hospital-based study conducted on 48 patients, and our observations are these, where we observed more of female patients, about 38 out of 48, and bilateral pterygium was noted in 30 patients. Astigmatism of more than 2.5% was noted in 29 patients. And most of these pterygium, they were in grade 1 and grade 2. So coming to the symptoms, most of these patients who reported to us, they were for cosmetic reasons and foreign body sensation. All the pterygium that was excised were subjected to histopathological evaluation, which showed both epithelial as well as stromal changes as shown in this table. And correlation of these histopathological changes with the clinical symptoms, that is the redness, was also statistically significant, which is confirmed by chi-square test. And so the second correlation was these histopathological changes with the grading of pterygium, which also showed statistically significant changes confirmed by the Fisher exact test, where here I would like to stress the dysplasia that was noted in 2 cases. So the association between these 2 diseases, that is pterygium as well as OSSN, is the common factor of sunlight exposure that results in overexpression of P53, whereas the role of human papillomavirus is unclear. Although male preponderance is reported, in our study we saw more of female patients, and acute inflammatory changes were noted in the younger age group, whereas elderly patients, they showed chronic changes. So this is one case which I would like to show here, which was an eye-opener for all of us, and which also changed the it changed our clinical practice of pterygium in our institute. So this patient who reported to us like a pterygium initially, the observation was like a pterygium, and on careful observation, here we see an OSSN that is emanating from the head of the pterygium. And subsequently, after subjected to histopathological examination, we found there was a conjunctival squamous intraepithelial neoplasia. And the last picture is the post-operative picture taken at 8 months follow-up. So to conclude, the clinical symptoms and appearance of OSSN and pterygium often have similarities, which makes definitive diagnosis challenging at times to avoid severe end of this disease spectrum, that is sight-threatening as well as life-threatening. So this calls for a pathological audit of all the pterygium specimens so that patients can be warned for the possible recurrence at a later date. Thank you.
Nice presentation.
Thank you, ma'am.
Any questions? Thank you.
Thank you. Dr. Nina Chris William.
Good afternoon. My study is on comparing ocular surface thermography at different temperatures using intelligent dry eye analyzer. Dry eye disease is a multifactorial disease caused by the loss of homeostasis, and it's very commonly seen in our OPD practice. There are several diagnostic tests to diagnose dry eye, however, many a time they are inconclusive, which made us explore other parameters. So thermography permits an indirect evaluation of the evaporation rate using a thermographic camera which operates within the infrared range. This concept was introduced in 1968. However, there is no commercial instrument to assess thermography. So our hypothesis was the change in environmental conditions in terms of temperature and humidity can alter the ocular surface temperature and trigger pain receptors, causing dry eye symptoms. So the aim of our study was to compare the ocular surface thermographic changes with severity scores in subjects with dry eye symptoms and asymptomatic individuals at ambient room temperature and humidity and a temperature controlled and a humidity controlled environment using a novel device. So this was a cross-sectional study done at a tertiary care center. Our sample size was 24. We had included healthy individuals in the age group 18 to 60 years. Initially the subjects were asked to fill the OSTI questionnaire, and they were divided into normal and asymptomatic based on the OSTI score. Then the OSTI questionnaire can be further subdivided into the ocular symptom subscale, the vision subscale, and the environmental trigger subscale. The study setting was ambient environment condition, temperature was 25 to 27, and humidity between 70 and 75, and control temperature was 20 to 22 degrees, and relative humidity between 55 and 60. So this is a novel device which is based on artificial intelligence and machine learning. So out of the several parameters it can assess, ocular thermography is one. We have a clip-on version on the slit lamp and the standalone device. So this is how the patient is analyzed on the slit lamp. This is a report generated, and you can see the last two images show the ocular surface thermographic variation, and it gives the severity scores. So the results, mean age group was 28 years. We had 7 males and 17 females. We compared the severity score at the ambient temperature and at the low temperature and humidity based on the OSTI score, and we realized that the severity score was higher at a lower temperature and humidity in both the groups. Then we compared each subscale. In the ocular symptom subscale as well as the vision subscale, we noticed that the severity scores are higher at a controlled temperature and humidity. However, those two results were not statistically significant, but in the environmental trigger subscale, we noticed that there was a drastic increase in the severity score at a controlled temperature and humidity, and it was statistically significant. So we conclude, our study showed that the ocular surface the temperature variation during the inter-blink interval was significant in those people who are symptomatic at a lower temperature and humidity. So other studies also showed that in dry eye individual there is a greater variation of the ocular surface temperature across the ocular surface compared to a normal person. And studies done by Morgan et al. Showed that the surface temperature was higher in a dry eye person compared to a normal person, and there was a greater decrease in the ocular surface temperature on prolonged eye opening. So we conclude that poor correlation signs and symptoms have called for novel technology, and recent advances in AI have overcome many pitfalls of the clinical testing, and ocular surface thermography severity scores are a novel approach to understand and diagnose dry eye disease. Thank you. These are my references.
Do you yourself took the readings of eye smart or?
Sir, the machine gives the readings. We have. I did the scans.
That I can understand, yes. Because what I find in this conference only, they are exhibiting the instrument in the exhibition halls.
Okay.
So they themselves could not take readings 3 or 4 times. They tested me.
Okay. So the result comes, actually we take the scan and the result is sent to us, because there are some PhD students who are analyzing the report.
That is true, but
we don't get the result immediately. It comes in a few hours. Because it's a novel machine, so they're just getting the...
Nice presentation.
Thank you.
I have 2 questions for you. So how did you calculate the sample size of 24?
Ma'am, this is a pilot study, so we took only the volunteers were taken for the study. So we took the initial.
So when you write sample size, there has to be a calculation, there has to be a formula attached to it. It cannot be a pilot study. You can just put any arbitrary number and say that this is the sample size. You can just say that these many patients were included in the study. And how did you control? I could not understand the methodology. Maybe forgive me for not understanding, but how did you do the control temperature and humidity?
Yes, ma'am. No, ambient temperature, we have a dehumidifier also. So patients at controlled temperature, we made them sit in the air-conditioned environment for 20 minutes, and we have a dehumidifier. So when the humidity was around 50 to 60, we assessed. So after 20 minutes of sitting in that controlled environment, we assessed the patient.
So it's uniform for everyone?
Yes, ma'am, for everyone.
Thank you.
Thank you.
Can we have Dr. Sachan? Dr. Shubhi Sachan.
Dr. Jitendra,
No,
he is back.
Absent.
Yeah, we just call the name and...
Dr. Jitendra is not here. Yes. And Dr. Rohit Bang is also not here. And we don't even have Dr. Shubhi Sachan. She's also not here.